especially you. Okay, this is the New York City REMAC meeting, January 22nd, 2019. Please answer when you're called. Robert Winchell. Joseph Schenker.
Here.
Michael Vatch. Robert Ackerman. Nicholas Alexandru. Who's going to be here? Chris Graziano. Eric Cohen. Mimi Langsam. Kevin Munjal.
Here.
Cindy Basilios. Dario Gonzalez. Glenn Seda. Bradley Kaufman. Doug Isaacs.
Here.
Nathan Reisman. Reisman. Not here either. Jeffrey Rabrich. Louis Marshall.
Morning.
Sorry, I'm losing my mind.
Dr. Marshall.
Are you in 30 minutes of a stroke center?
She doesn't know you that well.
That's right. Michael Redlener.
Present.
Michael Hilton. Laura Ivacoli. Great. Stuart Kessler.
Here.
Pamela Lai.
Here.
Peter Wire.
Here.
Paul Barbara.
Here.
David Benelli.
Right here.
Celia Quinn. Timothy Stiles. Mark Cantor.
Here.
Sharice Berry. Charles Martinez. Joseph Bove. William Fisher.
Here.
Robert Krupe.
Here.
Jessica Van Voorhees.
Here.
Arthur Cooper. Let me just count. 3, 4, 5, 6, 7, 8, 9, 10, 11. Wow, we just made it. 16.
Shoot. All right, well, welcome and thanks everybody for coming and taking your time to be here. First, I'd like to entertain an approval of the minutes for the November 13th meeting. Excellent. Perfect. Correspondence report, Marie?
Give me a second.
Right. Shut up. Could kill me.
Okay.
All right. While Marie gets her correspondence ready, even though it's on the record and it's not about the last meeting, I want to publicly apologize to Paul, wherever he is, for my behavior in the last meeting. Whenever you're ready, my dear.
Okay. We received an email from Shebra Hatzola appointing Jason Zimmerman to replace the late Dr. Friedman as medical director for Shebra Hatzola. He continues to be medical director for Instacare.
Murray, is there people in the room? Do you want to introduce him? These people don't know Jason. This is Jason Zimmerman.
Oh, I thought everybody knew Jason. That's Jason. No. Okay. Email from Charles Martinez saying he could not come tonight. Okay, this is not in order because I didn't type out my report. I'm going to be sending out emails to all the medical directors here in the city about this new initiative from the state, Pre-Hospital PECC. It's a Pediatric Emergency Care Coordinator. It's an initiative started by the state. They really want to push having more pediatric education out there and information for our providers. So I'll be sending this out. I'll be posting. There's also an application for agencies who want to participate. So
This is for agencies?
it's for agencies. They want every ambulance service to have a pre-hospital pediatric emergency care coordinator.
To get another job.
And what it is it's being a resource for education on pediatrics. They promote and share pediatric continuing education. Working on different types of educational enhancements. And I think that there's some money behind it. The state is providing some education for it. And the regional council, we already signed up to be a regional source here, but the more the merrier. We received from Dr. Peter Wire, and he will discuss this a little bit later under new business, a symposium that there is being created on the opioid crisis. I know he's looking for input from REMAC.
Looking for
to be able to list REMAC as a collaborator, endorser of the program, which doesn't require any input or resources from REMAC. I'm looking for one individual who, preferably somebody who's interested in and connected to the various initiatives on the opioid crisis to serve on the organizing committee. The date is September 20th that we're aiming for. And we're talking about the New York Academy of Medicine, several sections thereof, and the Department of Health is going to be working with us. But that's basically it.
I will be forwarding the email received from Dr. Wire on Stop the Dying, a collaborative community-based symposium. So you all can look at it and you can communicate directly with him. Fordham University let us know that they submitted all the paperwork to participate in glucometry. NYU has reported that all their paramedics and EMTs have been updated in the 2019 protocols. We received an email from Elizabeth Mellon. These are people that live here up in the Upper West Side. Basically, they have concerns about the new high-low sirens, and they're trying to get information on who to speak to about these sirens that I've never heard it myself. I don't know why. But if you live in the neighborhood, I understand it's pretty strident and it's becoming a nuisance. So I'll be putting them in contact with people from St. Luke's and also New York State Department of Health. Okay.
It's funny, we got both feedbacks, both sides of the spectrum.
Some people like them, some people hate them. I mean, they're sirens. I think everybody hates sirens, period, especially if you live in Manhattan and it's in like a canyon, so it makes the sounds even worse. Okay, we received requests for extensions for protocol implementation from Priority 1, Midwood, Instacare, Glen Oaks, Hunter Ambulance, Assist Ambulance. They asked for just 30 days, which we're basically past now, so they should have inputted. Richmond County Ambulance let us know that they completed their update for everyone. We sent a letter of support to Jacoby Hospital for their new PCI services. From Evan Mall, he sent an email and a CV expressing interest in filling the position of pediatric emergency specialist for New York City REMAC. So we have that spot empty, but we have our bylaws that hopefully tonight we're going to pick a date so we can have our next meeting and finalize, and then we can entertain these applications.
Is that a position or?
Yes. Yeah. Because there is I don't have it in front of me, but we do have a spot there.
I thought Mike Harris is the next one.
No,
He
he's
doesn't live
gone.
here right now. He's coming back.
He is coming,
Oh.
and he's an EMS trainee.
Well, that's something you all can decide who you want. We have another resume. And that's it. That's all I have for correspondence.
Thank you. Any question on the correspondence? Okay. Seeing none, I will move to subcommittee reports. The executive committee did not meet in the last cycle. Medical Standards Committee, Dr. Benelli.
Medical standards just met prior to this meeting. There are no motions being brought forward to REMAC. We had some discussion about needle decompression, which was sent back to the protocol committee for a final version 6. Once that is sent forward, we will be able to vote on it and approve it and bring it forward. Thank you.
Thank you. Great Quality Assurance Report, Dr. Redlener.
There was no meeting of the Quality Assurance Committee between the last REMAC and now, so nothing to report on that front. However,
Are there any updates on First Watch or the stroke?
well, I'd like to talk about the Stroke Systems of Care project. As you know, in the last meeting in November, we agreed that we should push back the start date of the Stroke Systems of Care project to April 1st. And we have an update related to the stroke commitment letters that were sent out to the hospitals. So we've gotten a total of 30 responses from the hospitals.
Have the map, do you want to put the map up?
I tried, I couldn't get it. I'll pass some copies of it around.
We couldn't get it up on that?
I couldn't, whatever, my email wasn't working, whatever.
Oh.
The problem is that it's 7.8 megabytes, the file, and it just like fails any institutional email unless you use a
So
private email.
I'll share some copies, I'll send a couple of copies around so people can take a look. But so out of the 30 responses, 22 of the hospitals said that they are or will be thrombectomy stroke centers, so either thrombectomy capable or comprehensive stroke centers. Currently 20 are doing the procedure, are willing to commit 24/7, and that translates into a map that something like 99.7% of all New York is covered within a 30-minute drive time. And so there's parts of the Rockaways that are not covered within 30 minutes. They're probably not covered within 30 minutes of a trauma center or a STEMI center as well. But I mean, I think it's a pretty robust coverage of the city itself. So in terms of that, I would make the recommendation to REMAC to move forward with the April 1st start date for the stroke systems of care. I think we can, I know that Joe has been in touch with the fire department, with Glenn, and
So the map that we have, unfortunately, we can't show it to you all. What it does show is that any hospital that does have the ability to, any area of New York that physically has the ability, because there's a hospital close enough to get to a thrombectomy capable center in 30 minutes, can do that. So the areas that are not covered within the 30 minutes physically can't be because of limitations of where hospitals are. And that really applies only to the tip of Staten Island and to the Rockaways, where there's just not a hospital close enough for them to always make the 30-minute window. In discussion with Glenn, it was felt that considering that we have 30 minutes for any place that physically can be within 30 minutes, that going forward with the April 1st date is doable, and that we should be going forward with that. So our current protocols, what we passed before the end of the year was for an April 1st implementation date for the LVO program. I think we can go forward with that and continue with that timetable. Any questions or discussions on that?
I'm sorry, how many hospitals did you say are currently active?
20.
Thrombectomy centers?
Yeah.
Provide thrombectomy care, yes.
Okay, so thank you to Michael and David for their work on this, and we'll start going forward with that next.
So some of the next steps that we need to accomplish related to this project, as we've said all along, we need to have a robust quality measure and tracking process, quality assurance process for the change in where patients will be transported. We've been working as a smaller committee to come up with some of those measures related to how we think that this, how effective we think that this can be for our patients in the region. Those draft measures will be shared with this committee probably next month for your review. But there was some final kind of tweaking that we needed to do as a smaller group that's been working on it. As far as the protocols and the education, the protocols I think should be ready to go out. I mean, there's nothing obviously that's changed since we passed them, but we wanted to wait until the standard protocols went into effect. So I think it's probably appropriate to send those and share those with the region around what the change will be for EMS. And with that, there is a regional education component that can be put on the LMS, and I think that can be put on the LMS now. I know the fire department has experience with the training piece of this, and I know at Mount Sinai we've done some of that training piece as well. Again, this will be shared with the region. So that will be, I mean, yeah, David, go ahead.
I think that parallel to sending out the protocols, we should also put it on the LMS.
Yep.
And I think that all the agency medical directors need to be aware that it's a time to start training their providers with doing this. Because if we do, April 1st is around the corner. So,
Yeah, I think it's a really collaborative effort. Michael and David really did a lot of work on this stroke training. I know Morty really worked with them a lot to have it regionally compatible and not just be fire, but be for the entire region. It's a real, I hope this is the first of many collaborative educational processes that we have. And when you guys do see the video, which I'm sure you all will, they really did a lot of work and they did a great job with it. So I want to thank them for the work that they put in.
Sure. So just then, related to that, there will be pocket cards and posters that will be provided for all of the agencies in the region. So that is part of the education process, and those will be shared in the coming weeks and months. Right?
yeah,
So
the goal is that everyone will be provided with a pocket card, and that we will provide for the agency's posters and EMS stations posters before April 1st, just as a reminder. Here, we're about to start this. This is what we're going to start using from now. Goodbye, Cincinnati Pre-Hospital Stroke Scale. And hello, New York City, yes, now.
So then that's the next piece. So there was some discussion we presented at the New England Cerebrovascular Consortium, where all the regions are discussing what their plans are. And one of the points that was brought up by one of the hospital stroke coordinators was that hospitals need to be brought along with this process. We're working on some material also for the distribution to the region, maybe a short video, some other educational pieces that will be available as well. So that people can share with their hospitals and their hospital systems, with their ED folks and the stroke neurologists that are at the hospitals. So we hope to have it's like a sister package for the hospital-based folks.
You can send out the posters too if you want, the EDs.
Okay, yeah, and the posters could be helpful. Yeah.
You just up the price over there.
What's that? Yeah. And then honestly, the chain as we start to train providers, that it's really a straightforward scale. It's really not much different than the Cincinnati Pre-Hospital Stroke Scale. It adds one element that is probably already going on in a lot of places in terms of measuring strength in the arm, right? So grip strength is the added feature to the Cincinnati Pre-Hospital Stroke Scale. I think it'll be intuitive. I think people understand when you talk about the rationale for this. It's understandable for all pre-hospital providers as well as hospital-based folks as well. So we've had some good response to the training and to the next steps. So I look forward to working with all of you. If anybody has any questions around that, or if you hate seeing my face on the video, then you can just return it.
With the pocket cards and posters, are we going to be getting a supply for the non-911 agencies?
Yes.
Yes.
What do you think, is it already done?
Not, David, maybe David.
Sorry, go ahead. Go ahead.
No, I don't know when it's going to
So
be
no,
done.
it's in the process of being produced. We tweaked it a little bit, and I'm hoping
Have you seen
it's
it?
not something that should take too long. We will definitely. I'm hoping it will be in the next couple of weeks.
Okay.
Okay. I don't have an exact date, but we're really fast at producing it, and we're producing something like 10,000 cards or something, which will cover all of the class.
Okay.
There's more information to come about how we're going to do quality improvement. There is going to be an EMS component, and agencies will be asked to share their stats and information around the stroke patients that they're taking care of. There will be more to come on that, about the specifics about how we think we can do that successfully. And in addition to looking at the hospital-based data to get feedback for the stroke patients. So more to come, and I'm happy to answer any questions.
Is most of your data going to be collected from the pre-hospital care reports, the electronic data, or is this additional data that's going
No,
to
I mean, any pre-hospital data will be collected. Well, we hope to have everything collected from the EPCR in whatever capacity. Hopefully not reviewing individual EPCRs. The other thing that's happening is that, correct me if I'm wrong, maybe the fire department folks can speak to it, but Stryker Health EMS is looking into putting New York City SLAMs into their documentation system, so that instead of documenting the Cincinnati Preoperative Stroke Scale, you're documenting the New York City speech plus LAM scale.
That's something we're gonna need to talk to
Yeah.
agencies in the region about. They have to trust that on their PCRs.
Okay.
Because you can't get it from the PCR if it's not on.
Right.
Correct.
The way the training material at the moment says that you either document it in the PCR or field if available, if not, you document it in the narratives. So hopefully, Doug, you probably can speak to this a little more, but we, at least at the health EMS level in the fire department, we're taking measures to address this.
Are you adding those fields to your PCR?
Well, sorry,
Doug.
I'll speak with David afterwards, but meeting with some leadership from the company, and I'll speak with David, see what timeframe he was given, but we can ask that to be certainly a priority. Some leadership that's coming to towns.
All right, thank you.
We have to talk.
All right, training and education.
We met on, when did we meet?
Like 2 weeks ago.
January 8th. We met on January 8th. I'll skip most of the reports. A lot of it is redundant from the report from last month. But the big thing was the protocol update rollout, which was I'll call it a good experiment that was met with mixed success. I think we have a good template in place now. This also was a collaboration of multiple committees ranging from protocol, REMAC, and others. Thanks to Paul, he provided us with a lot of information that was used as rationale. The idea was to put together a presentation, so to speak, a package that would show you what the old was, the new was, rationale for the change. The biggest piece in the past was not having that rationale for the change. I think made all the difference. Some of the challenges that we faced were the LMS itself. The LMS was not prepared to handle the volume that it got at the same time, which I think was good in a way because it prepared us for stroke, where we're going to have probably 9 or 10 times as many people, 8 to 10 times as many people going on to get the training done, because it's going to be EMTs and paramedics. So that was a big deal, which allegedly has been fixed. That's being tested now, and it is up and running and live on there currently. So hopefully stroke will work out that way as well. We learned some other things that we could enhance for the future, and that's basically what this was. It was a good starting point for future rollouts like this, and standardized regional education. In the future, we'll have things like voiceovers and make it a little more engaging, have a video perhaps for things like how to mix the push-dose epi when there is a component like that. So it's a little bit more interactive and engaging. We did learn that we probably need to be looking into a better LMS, and we're actively searching for that, because even with the current fix, I don't believe that that's something that's going to be able to support our long-term needs as a region, especially since we are putting more and more up on the LMS, and at least from what I'm seeing, there's a lot more usage on previous courses that have been posted. So that's basically it. In terms of the stroke training, I've reported here in the past what the basic idea is. It's going to be essentially the same thing that the fire department did. That was also a huge collaborative over the summer. There are 2 videos. In between the videos, there will be different testing mechanisms in between, and a package for the skill component. How to utilize the new assessment tool is going to be sent to the agencies with instructions, with several options as to how to run it. And it should be fairly quick and simple to do, anywhere from being able to fill up a room and do it with groups of people to being able to do it at 15-minute shift change kind of interactive. So that's basically that.
Okay, thank you very much. Also under subcommittee reports, I'd like Kevin to present the community paramedicine tag report.
Great, thank
Kevin.
you. I'm passing out 2 handouts. The first is sort of an overview, and the second is a draft of a letter from REMAC, which we'll be asking of the committee to consider. So the community paramedicine tag was appointed probably more than a year ago. So it's been taking a little while for us to get our legs under us. It is a sort of overwhelming problem or overwhelming challenge to kind of figure out how we're going to approach this. So on the sort of diagram that's laid out for you kind of emphasizes the need to address 5 key aspects. One is, what is the legal framework upon which community paramedicine in its New York version relies upon. What is the right paramedic training requirements? What are the operational components that REMAC does need to address or doesn't need to address? What is the right medical oversight and quality assurance requirements? And then, of course, what are the current projects doing, and what can we learn from them to provide some level of quality while not limiting the potential for this program to be widely available to patients. Not to dive into too quickly, but in terms of operations, capable field providers, are critical to the successful performance of community paramedicine. But we need to discuss how MAHCP calls can appropriately be initiated in our region. As everyone knows, Article 30 does require EMS to provide the initial response to emergencies. And so the actual way in which calls get triggered is something of a nuance that we do think the committee would like to address. Also, we're looking into whether or not alternative destinations are allowed after the assessment on scene. And these and other questions will ultimately be addressed in our final report. In terms of medical oversight, the requirements on the medical director need to be at least what we have now for overall medical direction of EMS agencies, but perhaps there need to be higher standards. And in terms of online medical control, a lot of the programs rely on direct telehealth with paramedics in the field. And so being very specific about what OLMC requirements we want to maintain or modify is going to be very important for us. In terms of paramedic training, there's a huge diversity of programs out there that require as little as by 20 hours or less, and there's some that require 350 hours or more. And we want to make sure that we're providing quality care in our region, but it's appropriate to the version or the model of community paramedicine that is going to be in place. So hopefully this provides a little bit of insight into sort of how broad the issues are for the community paramedicine tag, and we welcome input from the committee as well as participation from others in the room or elsewhere that have expertise to provide us. One of the things we wanted to do as sort of our first action or ask of REMAC is to try to make sure that we have as accurate information as possible about the existing programs in our region, or perhaps even in the nearby borders of our region. So we've drafted a letter that we would like to have the REMAC consider sending out, to essentially a request for information. Obviously the Mount Sinai program would gladly share this information that's in this letter, but we're hoping to get this information from any other programs that are active or even in the contemplative stages of acting. So basically, we ask for information about operational models, how MIH events are triggered, what types of units respond, describe how the program differs from quote-unquote traditional EMS. In terms of paramedic training, we ask for a description of the training provided, both in terms of duration and content. We also ask for whether or not there are any minimum requirements placed by that agency or hospital health system on minimum entry for the paramedics. How do they utilize existing REMAC protocols and interact with sort of what's authorized or not authorized in the GOPs? What are key provisions that are particularly relevant to the design of the program? Are there any state regulations or laws that are particularly relevant that the REMAC should be aware of in how they design their programs? And in terms of medical oversight, how is it provided, by whom, and under what circumstances is direct med control provided? So basically this is a little bit comprehensive, so I welcome feedback as to whether or not this is too little, too much information, but we would essentially ask of the REMAC to send this letter out to any known programs, but also perhaps to circulate it more broadly so that anyone that has a program that we're not aware of would also share their information.
So thank you very much, Kevin. Any questions on this letter? Any comments?
It sounds like you need a kind of templated survey that people can just fill out the information on, right? Rather than having to create a whole,
We did not want to make it multiple choice and leave it a little
no,
open-ended.
not necessarily multiple choice, but a template, so each of these questions, and they can fill it out, rather than having to construct a narrative, comprehensive narrative report.
Sure, I do imagine some of the programs would probably submit existing documents that they've created, but that's a good idea.
Survey.
Yeah, I mean, that was kind of what I was thinking as well. I think that, first of all, some of these questions, if you just ask them like this, you might not get as many responses as if you structure it and say, you know, what's your volume? Is it over this? Is it under this? How do you do training? Is it X hours, this hour? You might not get as detailed of information, but I think that if you leave it too open-ended, you might not get any information. And then there's certain questions, how do you utilize the current protocols that people might be a little hesitant to answer if we don't give them a little more structure to what we mean by that. Meaning, I think if you say to them, how do you use them, they might feel like, oh, am I doing something outside of the protocol? Do I not want to write that down? And really the key here is to get the information so we can kind of structure the system a little better. I think it's great. I think that we kind of, if we could maybe put this into more of a templated format or more of a structure, I think then the letter is probably ready to go. Any other feelings, thoughts? I think this is a great first step though, and I think it really is gonna help us, figure out where we go with mobile integrated health and how we establish ourselves as the leaders going forward.
There are a couple of people from the TAG present, so if anyone else wants to comment.
Thank you guys very much, and if anybody else wants to participate, please let us know and we'll get you in touch.
Quick question, what is the process by which it gets sent out? Would it be through, from Marie essentially sending it out? And does it have to be voted on, or is it just the executive committee has to agree?
So there's no specific voting on this. I would say we can do, there's no protocol change. We can do a hands vote that everybody who's accepting the fact that we're gonna send out a letter, and then we can still fine tune it, and the executive committee can fine tune the language before it gets mailed out. That's similar to what we did with the LVO letter that went out. It was, we asked this body to approve sending out a letter, and then the language was done in executive committee just to get it out.
Sound good?
Does that sound reasonable?
Tweak the language a little bit to reflect it being more in the framework of QA, you'll probably get less hesitation to fill it out also.
True. All right, so I guess we will take a hand vote. All in favor of sending out a letter, a community paramedicine, mobile integrated health letter from the region asking for information about programs, please raise your hand.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16.
Okay, and
Everybody.
the REMAC will work with you to finalize the language.
Sounds good.
All right, thank you very much. Next, regional council update, Dr. Krupe, if you don't mind.
Hold on, I
Unless
gotta-
you have it?
I have
Do
to
you
give
have
it
it?
to you.
I don't know.
Pass this down to Dr.
As the
Krupe.
past chair, I figured I'd give it to you. You got
Okay.
it, so you never read it.
Okay, so we last met, okay, November 27, 2018. The following nominees were appointed at-large members, including myself, Kiki Megan Farley, Kiki Martina Baccarella, EMP. I was appointed vice chair. The REMSCO activities included New City REMSCO taking part in NYC Surge Exercise Planning Work Group. The 2019 Surge X will again focus on the ability of hospitals to rapidly identify patients for discharge and evacuation. Territory mapping for ambulance agencies, REMSCO staff kicking with NYCM to push out instructions to agencies to submit their territory maps. NYC RX Stat Council on overdose prevention, providing monthly reports to New York City Department of Health and Mental Hygiene on naloxone usage throughout the city. There's also distribution of naloxone for agencies, distribution of naloxone leave-behind kits, assisting with New York State DOH migration of EPCR data to NEMSIS 3.4. Any agency beginning the transition process must submit a DOH 5136 form to REMSCO for regional endorsement. The council has approved the following EPCR applications: NYU Langone Hospital, upgrade to NEMSIS 3.4, data, senior care EMS changing to EPCR vendors. REMSCO is completing transition to a new emergency notification system. Once the transition is complete, staff will send out notices to agencies advising the new system and how the differences in future notifications. It was reported that the program agency is having issues with timely payment of vouchers submitted. This has to do with new staff at DOH offices and should be resolved shortly.
We got paid.
Right?
We got paid.
Oh, you got paid, good. Okay, that's always good.
Hallelujah.
No new application for transfer of operating authority or determination of public needs were received, okay, and no need application for determination of public need were received. Next meeting to be held January 29th, next week.
Thank you. Any questions for Dr. Krupe? All right, seeing none. Dr. Marshall, the CMAC update, if you don't mind?
Be my pleasure. CMAC met last week, and a couple of things are coming forward. Two of the big things are we now have a statewide BLS protocol that was approved. This comes forward with some changes that you might want to know about. One is the difficulty breathing protocol. They moved medication assistance to the CFR level so that CFRs can assist patients with their own medication. Carbon monoxide therapy, they had a transport to a hyperbaric center, and since the state doesn't designate hyperbaric centers, that was taken out, and language was put in to have a discussion with your medical director as to the appropriate location to transport the patient. Under the cardiac arrest protocol, there was a statement about avoid using an AED in a moving ambulance, and the discussion was that it was because, not that it will misfire, but it will miss an opportunity when it should fire, right? So because of the ambulance, but they said avoid, so that language was taken out and it was softened, so you don't have to worry about it. But yes, you can use an AED in a moving ambulance.